RJ is a 45-year-old male who presents with a caregiver at his group home due to concerns about RJ's refusal to take his medication for 3 weeks and increasing paranoia. His medical history is significant for bipolar 1 disorder, diagnosed at age 19, and alcohol use disorder in his 20s, in which he is in remission. RJ has had periods of remission for bipolar 1 disorder, where he was able to hold a job, but now lives at a group home for the last 5 years because his parents were unable to care for him due to health concerns. The group home staff is concerned about RJ's behavior, including paranoia and psychosis, and are hopeful that we can get him started on something to help decrease this. Pertinent positives include medical history of bipolar 1 and alcohol use disorder. Insomnia, has not been sleeping well at night. Group home staff report he is sleeping between 1 to 3 hours per night and might take a nap during the day for about 1 hour. He has had minimal sleep in the last 2 weeks per HAMP screening. He has had induced insomnia due to paranoia since he believes he needs to stay awake at night, thinking the staff at his group home will perform surgery on him while he's asleep. He will also only eat food that he prepares himself or prepackaged food as long as he is able to open it himself, and he believes some people at the group home are targeting him because they are high up in the government. He has also been non-compliant with his medications, including his lithium, bupropion, and lorazepam. And lastly, he's missed and refused multiple appointments with his PMHNP, in which he does not believe anything is wrong with him. Pertinent negatives include denies feeling depressed or sad for the past 2 weeks, denies hallucinations or delusions, including auditory, visual, or tactile, and he denies any recent use of alcohol, marijuana, or recreational drugs. He also denies suicidal ideation and homicidal ideation. Physical exam, he is alert, he has poor hygiene, and he is an unreliable historian. His affect is blunted, mood is anxious, and his speech is pressured. Differential diagnoses considered include schizophrenia, schizoaffective disorder, severe anxiety, severe obsessive compulsive disorder, major depressive disorder with psychotic features, and acute manic episode with psychosis due to bipolar 1 disorder. The treatment plan gravitated around an acute manic episode with psychosis due to bipolar 1. I would restart his lithium as this was previously prescribed. I would start 300 milligrams twice a day, and with the ability to titrate up to 600 milligrams twice a day as before. Prior to starting, I would rule out any pre-existing conditions, including gathering a UA, BUN creatinine, TSH with reflux, and calcium. After starting, I would check lithium levels to ensure titration is warranted, which is usually done around 5 to 7 days after initiation. In addition, I would also start a first-generation antipsychotic. I would start with risperidone, 1 milligram twice a day, with the ability to titrate up to 4 to 6 milligrams per day. If this is not effective, I would start olanzapine, 10 to 15 milligrams once at bedtime if this is not effective. This dose is based off of response and tolerability, which can be increased to 5 milligram increments, intervals of 1 day up to 20 milligrams per day. However, some experts say that some patients may require doses up to 50 milligrams per day for optimal response. So this is why it's important for RJ to follow up. I would assess RJ for response, which would include reduction of baseline symptoms greater than 50% within 1 to 3 weeks. If there is no response, another treatment plan that could be trialed would be to continue the antipsychotic and switch lithium to valproate. The typical starting dose for valproate would be 5 to 700 milligrams per day in 1 to 4 divided doses based on chosen formulation, usually dosed 3 to 4 times per day for immediate release. This can be increased to 250 to 500 milligrams per day every 1 to 3 days to reach desired clinical effect in serum concentration levels. He can continue lorazepam at 1 milligram as prescribed if this helps with insomnia. I would not restart his bupropion at this time, being that antidepressants can worsen manic episodes, so this would need to be revisited with his PMHNP once stable. I would have him follow up sooner with his PMHNP, likely and recommended within a week. I would go over a safety plan with the group home staff, warranting sooner follow-up, possibly in the emergency department if safety for himself and others has become a concern.